and I'd like to thank the organizers for this important symposium. As civil society, most of our work is being informed by findings from researches, and these are the platforms we normally get this information. So I'd like to thank the organizers for this important symposium. I will start by giving a brief background or just a synopsis about Zimbabwe National Network of People Living with HIV. It was established in 1992 by a group of 12 people living with HIV, and then officially registered as a non-governmental organization in 1999. Then ZMP Plus is an umbrella body that represents people living with HIV, as well as serving the interests of people living with HIV in Zimbabwe. In Zimbabwe, we normally work with support groups of people living with HIV. Why do we work with these groups rather than individuals? Of course, at times we work with individuals, but it's very important to work with the groups for easy coordination. So we normally work with people living with HIV in support groups or even in community-based organizations. Then our target groups is people living with HIV. We target men, women, youths, adolescents, children, key populations, persons with disabilities, ex-inmates, prison inmates, and other prison population. Why do we concentrate more on prison population? This is a hard-to-reach area, and because of security reasons, it's very difficult to penetrate in such environment, and as a result, they hardly find information related to TB and HIV. These are our thematic areas as ZMP Plus. The first one is the advocacy work on the rights of people living with HIV. That's the mandate of ZMP Plus. We are there to stand for people living with HIV, advocating for their rights. We look around issues to do with the drug stockouts, issues to do with service provision. So if those issues are in short supply, we then engage duty bearers and get them to task so that they can address some of these challenges. So that's one of our thematic area. Then the other one is community monitoring and social accountability. We will be monitoring HIV, TB services at health facilities. So we have quite a number of tools which we use to monitor such services. And some of the tools we use are the scorecard tool, and at times we also use the community treatment observatory tool. All these tools are designed to monitor TB, HIV services being provided for people living with HIV at different health facilities. Then we are also into TB, HIV treatment literacy. On this one, we provide treatment literacy for people living with HIV on issues around TB, on issues around HIV. We also developed a treatment literacy tool which you use as a guide to cascade information around prevention, treatment, care, and support. Then promotion of community-led DSD models for HIV, TB, and other co-infections. Then we also have community systems strengthening. Then the last one, networking and coordination. Then the unique role of civil society with support from TAG, Treatment Advocacy Group, under the Impact for TB project. Our capacity to advocate for the uptake of TPT was strengthened. We are being supported by TAG to have more information on TPT. The provision of a training on TPT and a guideline was developed to support our community TB work as civil society organizations. Then they also created platforms for civil society organizations from different countries in an effort to share experiences and strategies so as to improve on TPT uptake in our countries. Then there's also continuous engagement meetings with TAG through webinar, strengthens our TPT work as a civil society organization. This is also a platform for us civil society organization to share our experiences as far as TPT is concerned. Then as CSOs, we use different strategies in an effort to increase uptake of the TPT amongst people living with HIV in different communities. The first one is by creating demand for the uptake of TPT by people living with HIV in communities through sensitization meetings, trainings, and dialogues. Then the second one is community monitoring of TPT services at the health facilities to check on service provision and identify gaps associated with the provision of TPT. As I just indicated on the issue of community monitoring, is also our mandate to check on services being provided for people living with HIV around TPT and also around HIV at different health facilities. And if we happen to find a gap, we have to engage duty bearers on the issues so that we can come together and map a way forward on how best we can improve the services. Then establishing and strengthening supporting systems amongst people living with HIV to enhance TPT uptake and adherence. As ZMP plans, we have established the supporting systems within the communities, and these supporting systems are there they put people living with HIV at the center of programming, and these systems are there to improve the uptake of TB HIV services. Then engaging duty bearers on what can be done to improve uptake of TPT by people living with HIV. It is not only about creating demand for TPT and other services, but to ensure community ownership, sustainability, and meaningful involvement of people living with HIV in TB programming. So on this one, we are putting people living with HIV at the center of programming as far as TB HIV issues are concerned. We do this by establishing and strengthening community-based structures responsible for creating demand for services. For example, we have got what we call community health advocacy or agency. These ones we draw them from the constituents of people living with HIV. These are also volunteers. They are not being paid for. They only have the passion to spread on the information on TPT and HIV amongst their peers in the community. These community health advocates are also working at health facilities, providing health education, especially for people living with HIV, TB treatment literacy. Then we also have expert patients. These are clients who are on ART for a long period of time. Some of them have got 20 years or more being on ART, and we regularly give them information or current information in relation to TB, HIV. Then they would then cascade the information to some of their peers in the communities. And they can even work at the health facility, mainly on the OI department, where we normally have people living with HIV receiving their ART review. So it's the duty of also expert patients to provide information to their peers. We also have people living with HIV support group leaders. As I indicated, as people living with HIV, we normally work with people in support group for easy coordination. And remember, we also need the issue of psychosocial support. So we encourage the issue of support groups. So we, as people living with HIV, we work with support group leaders who regularly also receive TB HIV information and pass it on to other members of the group. Then we also have the community ART review group. It's one of the DSD models we have in Zimbabwe. So we also have the CAG leaders who regularly receive information and then cascade to some of the peers within the groups. Then we also have the peer educator model. This is mainly in prisons where there is also cell-based care. In Zimbabwe, in prisons, the prison inmates, most of their time, they are in their cells. They are released maybe for a minimum of 7 hours or a maximum of 8 hours. So most of the time, they'll be in closed doors. So we decided to come up with this model so that we trained the peer educators who will be then placed within their respective cells. And these peer educators provided information to do with the TB, HIV within the respective cells. And even if they find someone with symptoms of TB, they quickly identify that person and refer that person to the health facility within the prison setting. Then ZMP plus expertise in differentiated service delivery. DSD is just a client-centered approach, and it entails offering services according to the needs of a client. ZMP plus piloted DSDs in rural and urban areas targeting people living with HIV and realized the following benefits. More people living with HIV on ART were retained in care. ART adherence improved with no cases of loss to follow-up recipients of care, then transferred, relocated, and deceased cases were reported immediately to the health facilities. High viral load suppression was experienced by a number of people living with HIV. Then health facilities were decongested, and more time was created for health workers to focus on unstable clients. Then the success stories on DSD, we piloted, rolled out, and created demand for DSD models amongst people living with HIV. Then there was the needs assessment on DSDs, was done with support from IAS through ITPC, using community treatment observatory tool on DSD to identify recipients of care preferences. And on that picture, the picture is indicating some of the DSDs we have in Zimbabwe with the club review, fast track, outreach, family member review, community art review. Then we participated in the development of Ministry of Health DSD Operational Service Delivery Manual using our expertise on DSD. Then also developed and distributed DSD information, education, and communication material to communities and civil society organizations. There was also integrated other services in DSD, e.g. TB screening at community level, then issues to do with viral load testing. Expanding DSD for TB and TPT. Efforts to expand DSD for TPT is underway so as to improve uptake of TPT amongst people living with HIV. We can do this by creating demand for provision of TPT in communities using DSD models. Then DSD will improve TPT adherence monitoring amongst people living with HIV. Then distribution of TPT medicines can be done using DSD models to those eligible for it. Then directly observed therapy, weekly doses can be done using DSD models. Then TB screening can be done at community level using DSD models, and TB suspects can be referred to the health facility for further management. Then these are just community voices on TPT. The first one, I'm happy because there's now a shorter regimen for people living with HIV to prevent TB, and I look forward to have 3HP at our local clinic. Then the other one, I reacted to 6 months IPT and failed to finish my course because of side effects. Thank you for introducing 3HP, which has lesser side effects. Then the other one, I'm living with HIV and very afraid of side effects, but I'm happy to hear that there is now medicine to prevent TB with less side effects. I will go for it. Following our economic crisis as a country, I will not be able to buy the medicine, and I hope TPT will be offered for free. I was treated for TB some years back, and it was a hard moment for me because of pill burden. I had refused to go for 6 months IPT. This time, I will not make such a mistake. Prevention is better than cure. TB prevention is very important for us people living with HIV because we are vulnerable to it due to our compromised immune system. Thank you for coming up with new medicine for TPT, which is less toxic. I'm in a community art review group, and I hope we will be allowed to collect our TPT as a group so that we can monitor ourselves on adherence. Then the last one is from an ex-inmate. I am an ex-inmate, and I once suffered from TB during my incarceration because we were always exposed to TB due to poor living conditions. TPT is not provided in prisons, and it's my desire to see it being supplied in prisons also. Then challenges faced in an effort to improve TPT prevention. Then some people living with HIV, so those are some of their challenges. Then the key message is to drive HIV programs can't afford to ignore TBT prevention anymore. Then you have similar efficacy with IPT, less liver toxicity, better adherence and treatment completion rates, and lower risk of resistance. It's safe to use with the DTG. then it's expensive, but interventions to reduce the cost of rifampicin are ongoing. All countries need to set ambitious annual TPT targets and should use 3HP to meet a significant portion of their TPT targets. Thank you.